Morning everyone, and greetings again from Sydney. It's my pleasure to talk a little on patient-specific instrumentation for total knee replacement and give you an international perspective and what we're up to in Australia. But first, a little history on bone cuts in total knee. When total knees were first done, we did it freehand using our eyeball, and the 1970s saw the introduction of external guidance, initially with plumb bob and then various towels and rods. Computer navigation came in, and in 2009 we had shape match cutting blocks. And we now have image and multiple point registration based robots to guide our bone cuts. And my conflict of interest statement is that I've tried them all apart from freehand, and I'm unashamedly a computer navigation devotee. Our surgical goal with the total knee is to resurface the knee accurately and reproducibly as quickly as possible, with a minimum cost to the system to relieve pain, have good function, and have an implant that survives until the patient passes away. And we can achieve that with navigation. We certainly have demonstrated increased implant longevity. Navigation has a number of benefits, including the initial evaluation, which tells you exactly what the flexion contracture is, what the coronal plane alignment is prior to the surgery, but also directs the cuts, gives you a final evaluation in real time, and if you haven't got it right, it's up there on the scoreboard for you to fix, and it tells you a bit about the kinematics, whereas PSI just directs the cuts. So onto that concept of initial evaluation, let's draw a rugby analogy. If you're playing Johnny Wilkinson, you won't give away penalties in your own half because you know he's going to break your heart by kicking them all. And that's Johnny breaking Australian hearts when he kicked a field goal to win the World Cup final in 2003. So the question you have when you register your landmarks prior to a total knee, how will I perform the surgery with a flexion contracture of 21.5 degrees? That information is given to you that you know precisely what you are up against. More importantly, how do you know that you've achieved full extension at the end of the operation? Well, you can have a look and give the thumbs up, as we did here. It's a bit harder to know if you've achieved full extension and you've got a patient like this. But if you use navigation, you've got the answer. So along came PSI, and it has a number of benefits, including speed, decreased inventory, perhaps improved rotation alignment because it's image-based, and improved sizing, improved alignment over manual techniques. And if you're wearing your health economy hat, it's got a cost saving for the system, and it's got marketing potential. So a number of potential benefits. But the question we had was, is PSI as good as navigation for total knee? So we did two studies looking at the Vision Air and the Zimmer PSI. Both studies have been published. Fairly similar methodology for the Vision Air. We had 60 primary total knees done by David Parker. Pre-op imaging included high-resolution MRI of the knee and long films of the leg. I did the 30 PSIs. Preoperative imaging was an MRI of the hip and ankle and a high-resolution MRI of the knee. And I think it's important to make clear that the MRI of the hip and ankle and the Zimmer PSI did improve the concept of where the femoral head was in relation to the knee. The procedure was planned in the usual way. You'd vary the plane depth, the cut, and the rotation, and the blocks were delivered between 4 and 6 weeks later. With the surgery, it was routine exposure, navigation registration with Zimmer's Precision or the Zimmer OrthoSoft. The PSI jigs were pinned with the best fit, cutting guides were positioned and then cross-referenced with navigation and recorded. And we either used the PSI guide or we overrode, depending on whether there was a disagreement, and we used 2 degrees of variation as our standard, and the gold standard was navigation. We looked at alignment in the coronal and sagittal planes at femoral rotation, depth of cut, and the percentage that was in the threshold. Looking at the visionnaire, you can see that coronal and axial rotations were in the 70s. The sagittal plane was 55% within 3 degrees, which was quite unsatisfactory. 87% were within 2 millimetres of femoral cut depth, and the tibial cuts were a little more accurate. With the PSI, 97% were within 3 degrees for the femur and 83% for the tibia, and when combined, 73% were within 3 degrees. In the PSI, the tibial cuts were less accurate, with 79% being within 2 millimetres of cut depth. And it's important to point out that variations in cut depth are often a result of sagittal plane malalignment. So how accurate is PSI? Compared to computer navigation, it's certainly less accurate. The positive findings were that the manufacture and delivery was feasible, the sizing was quite good, and there's an excellent fit between the cutting jigs and the bone. The negative findings related to accuracy, particularly poor femoral rotation. The visionnaire had poor sagittal femoral angle, which did result in variation of depth of cut, and that's related to, I suspect, the technique of not knowing where the centre of the femoral head was with an MRI, and we frequently overrode both the visionnaire and the PSI. So why did I go back to nav? Well, in summary, I felt like I was flying blind. I was so used to having a whole lot of data in the operating room at the time of surgery, and I was just cutting along the dotted line with PSI, and it wasn't comfortable. My current practice is that I navigate 100%. My partners use CT-based robot using the image more for rotation, or they navigate, but they do not use PSI. What's happening in the rest of Australia? Well, the Australian Orthopaedic Association National Joint Replacement Registry refers to PSI as image-derived instrumentation, and the 2019, the most recent report, had 35,500 IDI total knees. In 2017, this represented 11.1% of the total knees that were done that year, and up to 12.2% for 2018, so it's going up slightly. And you can see from the graph here that there's no difference in the cumulative revision rate of IDI total knee versus non-IDI. When revision is required for IDI total knees, the incidence of loosening is slightly higher compared to non-IDI. Patients over the age of 65 have a lower incidence of revision in the first 3 months, and presumably this is because there's a lower incidence of early sepsis associated with a quicker operation. Computer navigation continues to increase in Australia. It's presently around 32%, and a very high uptake, perhaps one of the highest uptakes in the world for navigation in this country, is in this country. And the reason why, well, navigation has a lower cumulative revision rate for under 65s, as you can see in this green bar here. And for the over 65s, who overall have a lower revision rate, up to 2019 report, the revision rates were the same, but the 2020 report is going to show a slightly lower revision rate for navigated, even in the over 65 age group. And finally, I want to point out that today it's 20 years since we had the Olympic Games in Sydney, and they were wonderful times, and the world is now a different place. I have very fond memories of that, and I particularly remember how the French dominated the cycling. Congratulations to France for the way they performed at those Olympics, and congratulations to you, Sebastian, Guillaume, for a wonderful conference. I look forward to seeing you all in the flesh soon. Thanks very much.